Good morning, everyone. How's everyone doing so far? Good. Well, welcome. My name is Gabby. I'm the infectious disease program manager. Thank you for joining us. So today is our second day of health promotion and disease prevention track. In this session, we'll be presenting Indigi HIV, STI, HCV syndemic approach and best practice from our presenter, Jessica Leston. Jessica Leston, MPH, is the clinical programs director, the Northwest Portland Indian Health Board, where she focuses on systems and policy change. She began her public health career working at the Alaska Native Tribal Health Consortium in 2004 and has worked in tribal health since then. She believes strongly in learning from traditional Indigenous ways of knowing to help guide, direct, and strengthen our public health systems. In her life and work, she honors I'm going to butcher it. Thank you so much. Ilutik cultural value. We are responsible for each other and ourselves. Welcome, Jessica.
Amasa Neat Jessica DYU. Hi, everyone. My name is Jessica. I use she, her pronouns. My mother's side of the family comes to Turtle Island as settlers from Germany, from Sweden, and from Ireland. And my father's side of the family comes to Turtle Island as settlers from Finland and Austria, and also from Alaska, originally from British Columbia. And he's my Indigenous side of the family, Simpsian. We are Indigenous people are people of a place. Where we come from, who we come from, is how we learn, both from our family and that memory in our blood. So this is where my father's family is from, in Southeast Alaska. I have going to turn my phone off. And we can go ahead to the next slide. Okay, when I was asked to do this presentation, they were very organized, and they made me put, like, what's the title of your talk? And so I just kind of like threw in a kitchen sink, because I didn't have the time and space to sit down and really realize what I wanted to talk about at that time. But as as the weeks progressed, and as I thought more and more about what it was that I was really going to talk about, it was really how we can better take care of each other and our communities, using Indigenous values, Indigenous cultures, and Indigenous ways of knowing. And that means different things at different points. And hopefully, you all can help me better understand what that means as we go through this conversation today. I very much am open to having conversation during it. If you have questions, if you have comments, I am only here today because of all of the amazing people that I have learned from in my entire life, from my grandmother, from my sisters, from my friends, and all of the amazing mentors that I've had in the past and that I have now. Basically, none of my thoughts are my own. So I've just, all of this is a conglomerate of all information that I have learned from others. You can go ahead. So I wanted to start the presentation how I might usually end a presentation. And these first couple of slides are really the framing of how to talk about how I want to talk about HIV, STIs, hepatitis C, and the approach of moving forward in order to address them. And I think, especially over the last 2 years, we've heard a lot about syndemics, maybe over the last 5 years with the onset of the opioid epidemic. But really, it's a new focus on an old value, an old Indigenous value of understanding the context of where we're coming from and not pathologizing disease. You know, HIV is a thing that's separate from syphilis, that's separate from drug use, and it's not. It all goes together. And I think that in order to understand how to start preventing and treating, that needs to be taken into context. You know, already we know you can't have an HIV program that doesn't also treat hepatitis C, that doesn't also provide mental health services, that doesn't address social determinants of health and how someone's going to get to a clinic appointment. So this is really just the same thing in the context of this talk that I want to give today on HIV, hepatitis C, sexually transmitted infections, and sexual health. And you can have as many circles here as you want. I stuck to 3 other impactful things. Those are adverse mental health issues, substance use, and violence and oppression. And violence and oppression of Native people in general, of Two-Spirit and LGBTQ people, of oppression against each other and from other places of Native people. And the syndemic is in the middle of this. It's where everything comes together, and when everything comes together, you have these things that play off of each other, and it reinforces what's going on, and it makes it even more difficult to treat. You know, if you're not just treating syphilis with penicillin, if you're understanding the context of why the syphilis epidemic is happening, then it makes it more difficult to treat, and it's harder to move forward in doing so. So if you want to go to the next slide. And then this other model that I wanted to show was something that my colleagues and I have been working on, and that is to address HIV, STI, hepatitis C, and sexual health. And this is really like the bigger of picture of not just like what it is, where it's coming from, and that's the syndemic side, but this is what all adds to this problem. So we know that colonization, historical trauma, social determinants of health, and ACEs all impact any disease state, and also sexuality and sexual behavior and gender and your Native identity affects this as well. And that's encompassing everything, right? That's the individual, that's the community, that is who we are. And then these 4 quadrants of how we can better approach these diseases as a syndemic: clinical services, through public health research and research programs, through surveillance and epidemiology, at the individual level, doing individual interventions. But then at the center, something I think that, you know, we spoke about in the last session on immunization was policy and leadership, having effective policy and having leadership, mobilization of this community leadership to elevate the importance of addressing. I mean, look at what we've done with the opioid epidemic over the last 5 years, how much communities are involved with, or at least the communities that I'm working with are involved with in talking about the opioid epidemic. And I think that that's having a good effect, prevention wise, treatment wise. And so when you have leadership involvement and support, it's just really important. And so the next slide. So, you know, what I propose is using, you know, this way of looking at the syndemics in the green with this way of approaching intervention and action in the gray variants. And this is really important. But then if you click on the next slide, like all of this in the context of using indigenous ways of knowing, of cultural values, and using culture to heal. Because I think if you only use this, you know, in our indigenous communities, it's not enough. It's always important to understand this in the indigenous context with indigenous values at the forefront. So you can go ahead. So now I get really excited because this is when I start talking about sexually transmitted infections. And, even before COVID, there was a huge STI problem. There were huge increases in sexually transmitted infections across the board, especially in syphilis. Syphilis, something that, we hadn't really, like most clinicians hadn't even seen ever in their practice. And so with these increases, you can go to the next slide. I'm not 100% sure what it was. Okay. So with these increases and with COVID, decreased testing, more time at home and with loved ones, like not working, syphilis rates completely took off, completely. So you see from 2010 to 2019, how much syphilis has increased in the United States. So if you go to the next slide. And here you can see how much congenital syphilis has increased in American Indian and Alaska Native people. I mean, if you just look at the rates of syphilis between American Indian, Alaska Native and other races, non-Hispanic whites, huge disparities in syphilis. And the even scarier part is that it is being seen more and more in women, which is why we're seeing more and more babies with congenital syphilis, more and more long-term complications for those babies and stillbirths as well. So this is, if you haven't seen syphilis yet, I promise you will. And it is a huge issue right now in Indian country. Next slide. And this just shows, what the congenital syphilis looks like. And it's different in every region, congenital syphilis. And I don't only care about congenital syphilis, but it's a huge deal in our communities. But the rates of syphilis as well. We were in one area, we were out that was having a bigger syphilis problem. And in the NICU, in the regional referral center there were 8 babies with congenital syphilis and all were Native. There were no congenital syphilis babies that were not Native. So sorry, I just want to stress the importance of going back to communities and looking at syphilis. Next slide. And syphilis has been around for a long time, and the United States and the WHO, have been trying to do syphilis elimination plans starting in the 1930s, in the 1950s, in the 1970s. In the early 2000s, there was a huge push to end syphilis. There were very disparate rates in the Black population with women and congenital syphilis rates then, and like they almost did it. There wasn't any more congenital syphilis to really cause a blip by like 2005, 2010. Like they had done a good job eliminating it from heterosexual women, but they didn't do a good job of addressing it in men who have sex with men or gay men. Next slide. So what we know today is a lot, because there have been all of these plans for a really long time to address syphilis. And we know that we need to address a broad array of determinants for sexual health, and that there's these 5 components that are really key in addressing syphilis in the past: access to care, expanded partnerships, and these are partnerships like within the clinical system, and then also between the clinical systems and the states and the counties and all of those places, that the epidemics require tailored interventions depending on who you're trying to reach. Are you trying to reach men who have sex with men and gay men? Are you trying to reach pregnant people? Are you trying to reach young people? Each of those interventions to reach them are going to be different. That evaluation is critical. You need to know how many people you're testing. You need to know the positivity. You need to know the decrease in rates. And then it takes more than money. And So I talk about money a lot because like the presentation this morning, I think people who say it takes more than money usually are people who have money in their systems. So there is a baseline of funding that is essential that Native communities, that Native health systems are not getting. So I think money is needed, but it does take more than money to address HIV, STI, hepatitis C, these syndemics that we're talking about. Next slide. So there's a lot around syphilis. This is going to come full circle to the Indigi and everything as well. I'm not only talking about syphilis, but there's a lot to be learned from syphilis, just like anything else, HIV, Hep C, from Indian country. We have so many best practices and ways that we've addressed problems in the past. So this outbreak of syphilis occurred in central Arizona back in 2016, and you can see how their rates really increased here. Next slide. And so the key learning, I think, from this central Arizona example is like the importance of partner services and how important it is, just like it was in COVID, to elicit all of the partners and get them treated. And this is something that people in STD and HIV have been saying for a really long time. Unfortunately, mostly the states get money for partner services. They do the contact tracing and disease intervention at the state level. Rarely do you see that trickle down to, tribal communities, tribal clinics. However, now I bring this up because we have this infrastructure of contact tracers from COVID. And so the opportunity to sort of use this public health emergency from COVID in the context of other emerging epidemics like syphilis is really key. So, partner services is key when addressing syphilis, any STI. And then screening in the clinic was really important too. Screening not just in primary care as well. Usually primary care clinicians and their teams do a really good job of screening. However, there's other screenings, especially in this syphilis epidemic in the ER. People who are coming in, they don't have a primary care provider that they're seeing all the time. They're only going to see people in the ER. So important to screen in the ER, in jails, in the community setting, at prenatal visits. And then really just wanting to say, like, don't rely on the person to refer a partner. It's just not going to happen. So we need to take a more active approach of getting people in for HIV, STI, hepatitis C within the system itself. Next slide. And so another outbreak that happened in North and South Dakota in 2013 that went all the way until 2015 and really probably never ended. And you see what they did. They called in an EpiAid from the CDC. They introduced a EHR reminder, basically. They found all those cases, but it was good, probably because they introduced that prompt and they were finding the cases. And then they did on-site response where people came out, that was the EpiAid. And then, had to have continued education sessions because, that's a whole year goes by, you still have syphilis, you need to reintroduce all of these concepts, especially in areas that have a lot of itinerant or locum providers. Next slide. So from here, the main messages are the same messages that we're actually going to find from every single disease outbreak response for syphilis. So I'm not going to talk about these right now. Next slide. Another outbreak that happened this time in southern Arizona. Next slide. A lot of things that were found. I'm not going to go over them because like every single syphilis epidemic, we find the same exact things. And we find them like we've never seen them before and we don't know what to do, but we do know what to do. Next slide. These are a few things that we've learned from syphilis epidemics. And these are the things for like right now. like this current syphilis epidemic, depending on what you're seeing in your community. And that is presumptive treatment. Don't wait for a test result to come back if it's a partner of a confirmed case. Don't let them leave without treatment because you might not get them back. Having more field-based screening and treatment. So when public health nurses go out into the field for some contact tracing or to treat someone, or to make sure that they can also treat in the field. And that's through standing orders and some policy on providing field-based treatment. Rapid testing. Rapid testing in the emergency department, especially because if people are coming into the emergency department, they might not be coming in for regular care. Like I said before, they might not have a primary care provider. So people coming in with trauma or substance use disorder, make sure that they're screened and, if appropriate, start treatment. Utilization of EHR reminders. I know everybody's on different systems, but we do have our PMS reminders for syphilis that we've created in the past month or so that are available. And some of them include comprehensive, so like taking a more syndemic approach. They're including chlamydia, gonorrhea, HIV, hepatitis C, pregnancy tests, sometimes screening for substance use disorder. So we have all of those if anyone is interested. And then another site is considering just testing all blood draws for syphilis, so that it's not actually burdening for the nurse to draw the blood. Go ahead, next slide. And these are just, so those previous ones were considerations for the syphilis epidemic like that's happening right now because we have new tests and all of this. But overarching considerations for syphilis outbreak response are to expand case finding and prompt treatment and increase community awareness and engagement. I mean, and I think in the immediate, there needs to be a clinical intervention for syphilis now. If we're not finding and treating syphilis cases, the rates of syphilis are going to increase even more, and it's going to be almost impossible to stop the syphilis epidemic. So we need to have a lot more partner services, potentially using COVID outbreak response, expanded screening to populations that are at risk. And what we're seeing with syphilis right now is very tightly tied to drug use, extremely tied to drug use. Whether it's injection drug use or smoking drug use or even alcohol, but like opioid, methamphetamine, cocaine, especially methamphetamine because of the way it increases your sex drive, are very tightly held. And that's why I say, people who are in active drug use, they might not be coming to the hospital all the time, but they might go to the ER for something that is like very urgent right then. And that's why I just stress the screening in the ER. And then also, we're seeing a lot of people in this current epidemic that might not have stable housing situations. So if they don't have stable housing situations, going out and meeting community where they are in order to do screening and in order to do testing. And then, as I stated before, just ensuring prompt access to treatment, even if it's an unconfirmed case, but they are the partner of someone or have had contact with someone who has syphilis. And then another thing really important, increasing community awareness and engagement. Having public health announcements, having information about syphilis out there that the community will listen to, setting up testing locations in places that are going to have the most impact for the populations that are being impacted by the syphilis outbreak. Engagement with leadership. There, at one of the outbreaks that I had shared before, they had done a tribal decree stating, a syphilis outbreak, and that helped a lot getting community talking. And then using educational outreach, traditional prevention interventions. So next slide. The whole thing that I just talked about, which is what our normal talk is when we go out to clinics almost completely ignores what I wanted to start with. And I was saying this as a reflection upon myself as I was creating the PowerPoint. I mean, so sometimes, we're talking about syphilis here and substance use, because we see that tight connection in the syphilis outbreak. But very rarely are we also talking about violence and oppression or mental health when we're out there. And even more rare, like, are we taking in this outside ring here? And even more rare, are we using Indigenous knowledge and cultural values to address the syphilis outbreak right now? And that is something, that I found that I need to work on. So you're kind of like what you call a brain shooting. No, you're brain working with me. That's not the word either. That sounds really weird, but you're workshopping it with me. That's what you're doing. So like in the regular talks, in these contexts, I'm usually in clinicians' offices. I'm in the clinics, I'm doing clinical presentations, but that doesn't mean that I can't and I shouldn't, and it isn't necessary to address this larger picture, I think, when we're talking about it. So that's just more like a consideration that I had, and I know it's going to be more difficult to actually create that action and to understand what that actually looks like in all of these different communities. But I think it's something that needs to be intentional. And so, like, as we're continuing to address HIV, STI, hepatitis C, it's going to have to be an intentional work to address it in a more holistic context, taking the syndemic in mind, understanding everything that actually needs to be done for an effective response, and then in an Indigenous lens. So, talk about complexity. I do, this is very complex, but it's just a challenge for myself. And I think that we're all going to have, that we all should have, when we're moving forward with designing these approaches to HIV, to syphilis, to opioid response. Because if we're looking at all those individually and only, the Western medical model definition of what it is, I don't think we're ever actually going to impact and create what we all want, which is health and wellness. Next slide. So in this bigger context of sexual health, there are for sure some important things to consider. It is in this paper right here that I worked on with a couple of colleagues, and it's probably going to be laid out way better than what I'm going to talk about it right now, for reference. But next slide, in this context of sexual health. So I have like a half hour, is that it, right? Okay. So next slide. Oh no, it's all this stuff. Can you just like go through this? Thank you. So in the paper, we address the social and behavioral context for sexual health among American Indian and Alaska Native people. One is the complex and fluid values that Native people have with their identities, with their relationships, and with sexuality, and acknowledging these in the context of addressing sexual health, just like Misty had talked about earlier today. What kind of sexual health information, prevention-wise, are youth getting in the schools? It's very heteronormative, and that's the information that you're going to get. And it's very sex pregnancy prevention focused, right? It's not about forming good relationships with partners and understanding relationships and open relationships in which you can talk about all of this stuff. And then the impact of colonization and forced assimilation, the removal of identity, the removal of cultural values, the removal of very ingrained gender systems in most tribes that did account for diverse genders. All of this means that American Indian and Alaska Native people have and express historical trauma currently, right now, every single one. And that STIs in American Indian and Alaska Native people are associated with a lot of different factors. Alienation of Two-Spirit and LGBTQ people, intense social pressure in a lot of situations to have sex. And that's usually in drug use situations, and then intimate partner violence. All of these things that we heard this morning in the conversation that was led by Maddie, Misty, and Brandon. Next slide. But also, just like in the syphilis response, in this more comprehensive Indigenous-driven paper, we did focus on community-based innovations, not just clinical. It's just one slide, but how Alaska has built the community health aid model that is, currently moving down into the lower 48 in order to address the lack of healthcare professionals to adequately build health and wellness in our communities. And also the ECHO program that was created by the Northwest Portland Area Indian Health Board. There are other ECHO programs that are run by academic institutions and states, but Northwest Portland Area Indian Health Board felt very strongly that they should stand for Indigenous leadership for Indigenous health, and has created a very extensive ECHO program based on that value. Next slide. And then tons of community behavioral interventions that have been developed with and by Native people for communities. These are all available on the Healthy Native Youth website. But there are these interventions for Native youth right now that are sex positive, that are talking first, and are, and most importantly, like in the Indigenous way. Not, weren't created for white non-Indigenous people, but created for Indigenous people. Next slide. And so just like with the syphilis, with various different health system interventions and sexual health interventions, there are great lessons to be learned from our communities. If only we had like, a better way to share those stories and share what's worked, and a way to implement that across Indian country, instead of just singular little things happening, like really great singular little things. So, even in this paper, the way forward was to develop community developed interventions that with broad implementation, research knowledge gaps, understand what is needed in order to improve surveillance, clinical care, public health interventions. And there was a fundamental need to understand sexual health and STIs within the complexities of American Indian and Alaska Native centered histories, cultures, structures, and social determinants of health. So I think you can go to the next slide. So I think like all of that to say is this model and the Syndemic model is continuing to come up in a lot of HIV, STI, Hep C, syndemic work, and that it could be a good model coupled with, can you go to the next slide? Coupled with the syndemic approach and the indigenous lens, to move not just HIV/AIDS, not just STI, but like the whole of health and wellness forward. And so that brings me to what the original title of the presentation was, and that's the Indigi, or the Indigenous HIV/AIDS Strategy, that is taking a syndemic approach to addressing basically ending the HIV epidemic. Next slide. So you can read the vision of the group, and basically the intent of the Indigenous HIV/AIDS strategy, which also is just completely interwoven with STIs and hepatitis C, was not necessarily to replace the national strategy. A lot of work has gone into the national strategy, the national HIV/AIDS strategy. But this is a companion strategy to walk alongside that national strategy that really takes an indigenous approach, that is built to be modified for our communities in order to effectively address HIV, STIs, and Hep C. Next slide. This is just the advisory committee. So we have representation from each of the areas that are on our advisory committee. And we have mostly monthly meetings. And the Indigi is actually going to be released in October, hopefully for the National US Conference on HIV, AIDS, and Viral Hepatitis. Next slide. So the main messages after a year of working together from this national strategy are centered on sovereignty, on cultural responsiveness, on relationships. There's a lot of relationality in the strategy, awareness, capacity, clinical resources and services, stigma, and data systems. I'm not going to go through every single one of them, but I will provide a little bit more information on some of them. And again, hopefully you all see this strategy very soon. Go ahead. Sorry, my voice is just dry. So we're calling them main messages right now. But the first one was a respect for Indigenous sovereignty. And that's in the design and delivery of services. It means that we as Native communities, as Native health systems, know what's best for our systems, for our people. So the first goal under this section is to increase understanding, recognition, and respect related to Indigenous sovereignty. And I guess I just wanted to take a moment here, looking at this first main message and goal in the context of everything that we talked about today. And like maybe me stop talking for a minute and hearing from you is how can you see this goal and objective applied to HIV, to STI, to hepatitis C, the whole syndemic approach? What is its pertinence? Thought you were raising your hand, but you were just swatting a fly. Yeah, it's okay. Yeah, so in the context of everything that I sort of spoke about today, the group has decided that sovereignty is important when we're addressing these more clinical issues. And I think that is an Indigenous approach. Those are our Indigenous values that we have placed upon this strategy. And so basically, how can you see this being married to addressing HIV or hepatitis C. Because usually you don't see sovereignty in the national plan, right? So it's going to be more difficult to do and to measure sovereignty in our plan. It's not a traditional Western approach to how you end HIV. Why is it important? And how can you see it applied? Man in the back there in the red shirt.
I know some of these examples in the field, so again, I'm saying things that are not my own ideas. You see some tribes are very aggressively setting their own policies on certain how to expand access to care, expand treatment, sorts of things that way on their own community. I've seen some on one where they've been strong with the state health department because you look at the resources the state is getting for certain conditions. And where these conditions are really disparities are, it doesn't match. So when you've got 50% of your, say, syphilis patients on an Indian country, only 10% of your resources going. Just not person. And that sometimes happens just through state inertia, which don't realize, or sometimes it's excluding. But anyway, those are I'd say policies and states on this.
So is there like a collaboration with this may be just my lack of knowledge, but is there collaboration with data sharing between the state and like how like the data is put into?
It varies state to state. We've seen one state that is actually not able to get to the state database. They're trying to fight for that access, where neighboring states, the tribes can get into it. Again, it's a huge difference on partner services, which what we saw here is really a cornerstone of these findings. Right, when you find that patient, better for the patient, but you're also stopping the transmission.
Yeah, and I was just saying that because learning is not all indigenous people live on the reservation. So if they're living somewhere else, you need to be able to share the data, and then it increases, the awareness when you go and present it to tribal council for whatever you're trying to change policy or legislation to actually expand, the awareness, I guess.
Yeah, there's huge implications for sovereignty in data, for sure, and data care and data access. And I think, Brig, your example made me think about COVID and how there were tribes that made resolutions and stopped people from entering their reservation in order to prevent the spread of COVID. And that was the application of tribal sovereignty in a public health context. It's really easy to think about, I think, tribal sovereignty in fishing rights or land rights, but often a little bit more difficult to think about outside of the context of compacting your health system, and just getting to the individual level of a healthcare issue. Daniel, I know that you had your hand up. Did you still? No. Mm-hmm.
Online, Maureen James, in response to your question, mentioned the same as the HIV prevention trials network with Johns Hopkins in 2003. Behavior modification is best addressed across all community areas without exclusions. IHS must obtain tribal buy-in to all initiatives as a multi-pronged approach for the best possible outcome.
Yeah, definitely agree. Treating really the entire community, right? Which is a very indigenous approach to treatment of HIV, of syphilis. Dr. Brown. Mm-hmm.
You can't have a relation. It's an outside expert on anything.
Mhm.
without first developing a relationship, respectful, mutual.
Absolutely. Yeah. Yeah. And that's a really good point. Okay. Next slide. Okay, so another thing that another main message was around cultural responsiveness. And so ensuring the delivery of culturally responsive services. This goal that I chose from here was to support the integration of Indigenous philosophies of holistic wellness into Indigenous health systems. And so, reading through this for a minute, same question. Um, how could you see this applying in the context of HIV or, STIs, hepatitis C, the syndemics? Mm-hmm.
She was saying, there's things about harm reduction and stress exchange program. It's meeting the people where they're at, and then also I like how she said when she was talking about policies and procedures, it's not about making it the way that we want it, it's the way that they want it. We collaboratively should really are. And that's what I want to think about as a one thing. Not just about tribal sovereignty, but also providing, our and how we collaborate together. It's so different from the Western.
Yeah, thank you. I mean, I just appreciate you all going through this little session with me because, I think Vicky's on the advisory committee. We're thinking about these things, but in the next year, we're taking it through the dissemination and implementation phase. And really it's so important, I think, to all of us, to myself, that, this document isn't just out there, and that people don't just go to the clinical section of it and say, okay, well, we need to increase HIV screening. We need to increase PrEP usage in our clinic. That's really important. But I think if you're taking this indigenous approach, which is a better, more holistic approach, and one that's going to work in our communities, it is even more important to think about all of these other things, because these other things are the harder things. They're the things that make you not uncomfortable in a weird way, but uncomfortable because you might not have the exact answer with how to implement them. Look, that's why I'm up here asking you, how are you going to do this? Because I don't think that there's a way. It's many different ways, and it's through these cycles of continued learning from other tribes, from each other, and from the community as well. And I think that the Indigi is going to be a really useful tool to help communities that choose to potentially use it reframe some of the ways that they're addressing syndemic things, or even just health in general. It could provide a useful way to address health and wellness generally in their clinic by acknowledging that it doesn't just happen in the clinic. We know that 50+% of healthcare happens outside of clinical walls, So it's also going to be important for us to focus on healthcare in those other places where we go to school, where we work, where we play, where we eat. Next slide. The next slide is to strengthen. One of the main messages were strengthen partnerships. And this one was to strengthen partnerships within and across Indigenous communities to improve systems of care for Indigenous people. And I guess in this context, I'd have, unless you just want to answer the question that I've been asking to the main messages the last couple times, what are ways that you would think would be useful to help increase partnerships, within Indian country, to better learn from each other, to have more conversation around, not just Indigi, but potentially these, new ways of looking at things. Mm-hmm.
Going back to your other slide too, so the big is the community health workers, and there were the people that live in the actual small city, and then we also have like the peer-to-peer is also another way to get people to actually collaborate together and like want to feel like it lessens the stigma of feeling like they're the only one. So when you hear from other peers, or you hear from the community health workers, they come together, to create that partnership, to say like, okay, we aren't alone. This isn't just something that you have to push and hide, but together we can improve our systems by listening. So if I hear her, it's more connection, and that's what this whole thing was, healing through connection. So if I hear your story, I'm more to speak about my story, and it's continue.
Yeah, I thank you for your answer, because I was speaking, my mind was on like a larger frame of like connecting community, but then you bring up a really good point of how communities themselves can have networks set up where these relationships and connections are fostered, maybe not like on a national scope, but in the community with people in a certain area that are also extremely beneficial.
That's what we're doing. When you get to hear what other people are doing and see visuals of pictures and things that are working in their community. I was in a session on Tuesday morning, and it was like we've been struggling, just as an example, with improving breastfeeding numbers in our community, and Seneca is doing this program, and it was like, man, that's it. I mean, there's why don't we talk? And I think that when you draw from each other, it's like, okay, this is working, and this it would work in ours. So I think sometimes just like almost like listening sessions and connecting, but you got to create the venue for people to hear each other. Yeah. And we get so caught up in our own centricity in our own community that we forget other people are doing really great things, and just having venues to be able to hear that is really important.
Yeah, I agree. But no one wants to join another echo, right? I mean, I do. I always want to join another echo, all the time. But yeah, actually, I guess that makes me think of like, well, what are other ways to share? And I think people really miss things together in person. But then, like, we all know this knowledge here. How do we increase sharing that out to other places as well? Yeah, I'm sorry.
I was thinking about forming partnerships at the different stages of program design. So sometimes we get into it after we've already decided we're going somewhere and then we look for it. But if we're on a strategic planning for years, we want to address this. And we can identify partners early, and we can leverage resources together for me. So that's kind of what I guess I was.
Yeah, I think that that's great. And I think that I think, like, USET, Northwest Portland area, everyone has their health boards and everyone has their epicenters. And I do think that is a way of, connecting and, bringing together all the different tribes. But I guess, like doing more of that. I just think of like, the states get funded for HIV, STI services, and they're always on calls with each other. And they're always on calls with the CDC, National Coalition of STI directors. And so they're in these partnership circles already that a lot of tribes aren't in. So I guess it's kind of, I'm kind of thinking about what you said, that having more tribes join state calls, National Coalition of STD directors calls, and then having our tribal health boards set up more opportunities for us to all connect, just like, the CDC is connecting all the states in a region. And I do think that that's what we're doing with that, and trying to do with that, is increase that collaboration. Next slide. I think, I don't know about you, but I'm done. So we don't need to do the same thing with this slide. I listen to myself and I'm just like, not another one. Go ahead to the next slide, just next slide. Yep, this is my next slide. No, the picture. Look, we're all using pictures, right? I just wanted to reconnect with my picture. This whole, thank you so much for this conversation. I think that I've learned so much. I'm hoping Greg is in the back taking some notes and not just checking email.
He's gonna sleep.
Yeah, he's gonna sleep. But this is where we learn everything, is through connection and through relationships with other people, like all different kinds of people. And we are in this place together, and we are people of a place, Native people. And we learn from things in that place, from the environment, from the birds, from the water, from our stories, from each other. And so I just can't tell you how much I value being in this place with you all being interested in having this conversation with me. And hopefully, continuing to think about this and maybe be connected in the future to talk more about implementing the Indigi House in your communities and how you might be able to use my gray and green models and Indigenous lenses and take them even further. So just thank you so much. I appreciate it.
Well, Jessica, thank you so much for your wealth of knowledge. As our token of our gratitude, USET would like to present this gift to you. You're welcome. Thank you. Please be aware that we do have the evaluation packets that we presented out. So if you don't mind still making sure that you're filling those out. And as an addition, once you are finished with that, there is a box at the registration center.